Hi everyone, and welcome to the Otolaryngologic Clinics podcast series. I'm Taylor Hayes, the managing editor for the series here at Elsevier. Otolaryngologic Clinics is a bi-monthly publication consisting of review articles focused on a central topic. Today, we will be discussing the April 2025 issue dedicated to the nasal valve. Here now is the consulting editor, Dr. Sujana Chandrasekhar, to lead the discussion.
Hello, I'm Dr. Sujana Chandrasekhar. I'm the consulting editor of Otolaryngologic Clinics of North America, and today I'm speaking with Drs. Robin Lindsay and Shekhar Gadkari, the guest editors of the April 2025 issue of Otolaryngologic Clinics of North America, which is on the nasal valve. Dr. Robin W. Lindsay is Associate Professor of Otolaryngology at Harvard Medical School and Facial Plastic and Reconstructive Surgeon at the Massachusetts Eye and Ear Infirmary in Boston, Massachusetts. Dr. Shekhar K. Gadkari is Assistant Professor of Otolaryngology Head and Neck Surgery at the University of Miami Miller School of Medicine in Miami, Florida. They've put together a comprehensive and engaging issue of the clinics on the nasal valve with 17 articles by expert authors, including some great online video content. I'm excited to speak with them about it today. Welcome, Robin and Shekhar.
Hello.
Hi, excited to be here.
I'm very happy to have this opportunity to talk to you. I'm going to remind our listeners that you can access this and all of our podcasts, which is one per issue, plus a couple of special article series since 2017 at our website, which is www.oto.theclinics.com. And wherever you get your podcasts, you can also access all articles, online content, and entire issues at our website as well. So let's get started. Robin, Dr. Lindsay, the birth of this issue happened when you and I decided to take a walk at a break during a meeting and walked on the beach in Florida. And we're talking about, this and that. And you introduced this ear surgeon who's speaking now to the intricacies of the nasal valve. So first, I want to thank you for broadening my horizons. And second, can you explain to our listeners what is the nasal valve and has the definition of the nasal valve changed over time?
Yeah, I'd be happy to. So I'd like to point out to the first article in this edition by Dr. Liu, Dr. Chen, and Dr. Wang at UC Irvine. They have a great figure to start off the chapter that demonstrates the internal nasal valve and the external nasal valve. The internal nasal valve is commonly known as the angle between the septum, the upper lateral cartilage, and bordered by the inferior turbinate inferiorly. The external nasal valve is really just the nostril. And is impacted by the lateral crest of the lower lateral cartilage and the septum and the nasal floor. Also, there's a figure in this article that demonstrates the nasal musculature, which is really important for nasal function and something that is often overlooked when we're thinking about the nasal anatomy. There's also several formulas in the chapter that can get a bit overwhelming. What is important to note, the nasal anatomy is very complicated, and there's not one formula that helps us to understand the nasal airflow through the nasal passageway. However, there are some unique principles, such as Ohm's law, where when you increase resistance throughout a non-compressible tube, the flow decreases. Also, we commonly think about Pascal's law, where resistance varies throughout a pipe, and it's inversely related to the radius, and so to the power of 4, which demonstrates that millimeters really do matter inside of the nose. Though how we all know that the nose is not made of concrete and it's compressible. It's made of skin and cartilage. And so we also have to think about the Bernoulli effect, where as you increase velocity, it leads to a negative pressure inside the nose, which can lead to nasal valve collapse. Also, if we look at figure 4 in the article, it shows some computational fluid dynamic imagery, and it really demonstrates those levels of high resistance inside of the nose, shadowed in red. That the red demonstrates high areas of resistance, and we see that in the area of the internal nasal valve. Furthermore, in Figure 4, they discuss Reynolds number. Reynolds number is a non-dimensional ratio of inertial forces to viscous forces within a fluid. Basically, if Reynolds number is over a certain level, it causes turbulent airflow. Turbulent airflow is when patients start noticing symptoms of nasal obstruction. And you'll notice in Figure 5 that this Reynolds number is much higher anterior to the nose in the area of the external nasal valve and the internal nasal valve.
So when you're seeing somebody in the clinic who's presenting with what you think is nasal obstruction due to internal nasal valve issues, you're not going to calculate all these numbers. How are you transposing sort of the physics that you understand so well and frankly explained so well that I get it? How do you transpose that to the patient in front of you to try to help them know what it is you're trying to address?
What the computational fluid dynamic modeling and the different laws help us to delineate is the areas of high resistance. So we know the areas that are important to nasal airflow inside the nose, and we know when those areas are anatomically narrow in an individual patient, that by opening those areas that we decrease resistance and we improve the symptoms of nasal obstruction, which we'll talk about more in a later chapter. It's really just showing you the areas that you want to pay attention to during your physical exam.
Thank you. That's really, really a great way to start this off. So I'm going to switch over to Shaker. So Dr. Gadkari, how do you like to evaluate patients who present to you with just a global statement, my nose is blocked and my nose is obstructed, I can't breathe well?
Yeah, I mean, this is how most of our patients come to us in our clinics. It's kind of a global complaint, and it can be challenging, and a lot of people have their own ways of doing it. But really, as Dr. Lindsay just mentioned, you kind of want to look at every area that could be narrowing it and rule them out one by one to see if there's a surgical treatment or a medical treatment, what that could be. And in this article, just for that reason, we have a really good contribution by Dr. Eng and Dr. Robicek, which looks at the preoperative assessment of the nasal valve. In kind of my experience and a lot of facial plastic surgeons' experience, including what Dr. Eng and Dr. Robicek mentioned, you want to do a comprehensive physical exam. And when you're doing that, you look at all the areas of resistance that Dr. Lindsay was talking about. You look at the internal nasal valve, you look at the external nasal valve. You're going to look at whether the cartilage is adequately supporting the nose, if they've had previous surgery, if some of that cartilage has been resected. And then you want to make sure, even if, suppose you're a facial plastic surgeon or you're a sinus surgeon, you want to look at the other things to make sure you're not getting tunnel vision on one complaint. So you want to see, do they have polyps? Do they have sinus disease and frequent sinus infections where the mucosa is swelling? Are their turbinates large? So it's kind of a comprehensive exam. And in this article, really, they encourage everyone to look at everything in a systematic way, look at whether there's a widened columella, ptotic nasal tip, there's deviation of the septum, weakness of the sidewall, and incorporate all of those things into your physical exam using both how everything looks when the patient's breathing, their history, and also your physical exam maneuvers like the modified caudal, or if they have been using nasal cones or nasal strips, what's actually helping them. All those things can kind of contribute, and that, in a broad sense, is how we look at patients with nasal obstruction.
You know, I was listening to a Backtable ENT podcast, and I have nothing to do with Backtable ENT other than I'm a fan. It's a great free resource about all things otolaryngology. But I was listening to a podcast recently about nasal obstruction in obstructive sleep apnea. And the person they were interviewing was talking about the fact that people always say modified caudal. And what he finds is that many of our colleagues may not be doing that test properly. So how does we all can access a cotton-tipped applicator, right? So how does one do a modified caudal correctly?
Yeah, that's a great point. I think especially people who rely on it for looking at nasal valve can probably be a little bit more picky when it comes to how people are doing the modified caudal. I mean, every bit of information you get is good information, but it is important to do it right. And in Figure 2 of this article by Eng and Robicek, they show an example of how you would do a modified caudal. But I think some tips or some important points that I've kind of learned as I've seen many, many patients with it is, and something they mentioned in this article as well, is that anyone that you put a Q-tip in and crank to the side, they're going to breathe better because your arm is stronger than a cartilage graft. What you really want to do is be gentle and show if a small amount of force that you could actually mimic with your cartilage graft can help the patient. So what I do, and they didn't mention this in the article, but I think it's still a helpful tip, is the first thing I do is just touch their nose without actually supporting it. And some patients are so desperate for help with their nasal obstruction that they'll say, that's the greatest improvement. And then I'm a little bit more wary as to what the rest of the exam is telling me. Then after that, I tell the patient there's no right or wrong answer. And then we support the nasal valve. You support the external valve where you could put a cartilage graft to support the external valve and really gently hold it out and plug the other nostril and see if their breathing gets better. Then you can do the same with the internal nasal valve. I think the other thing that is important to note is that if the septum is really deviated, then just giving them a little bit of support there will improve the external valve. But really what you're doing is moving the cartilage structures away from a really deviated septum. So that can be a little bit misleading as well. But I think those are the general tips, is to not do it with excessive force and to do it very gently at first to see if the patient is kind of in the mode for really being able to tell you what you expect to see on that exam. But supporting the external valve at the level of the nostril and laterally, and then at the internal valve, it's important to note that a normal internal valve is only 10 to 15 degrees, and the Q-tip applicator, if you use the big end of it, can really widen that. So you just want to be careful that you're not overdoing it with any of these exam maneuvers.
You're talking about doing both anterior rhinoscopy, and then do you also rely on sort of deeper nasal endoscopy to maybe look and see what's happening to the septum and the turbinates more deeper into the nose?
In terms of nasal endoscopy, they talk about that in the article as well, and mentioned that there's a significant number of patients that undergo surgery just for what they see on scope exams. Now, whether or not you scope everyone that comes into your office, I think that is completely up to you as an individual provider. I think it kind of varies. But one thing that is useful about nasal endoscopy is, one, you get a really good view of what is going on. But I think even more important is you can show the patient exactly what's going on, because they're not going to understand all these terms of deviated septum, turbinates. So if you point out where the structures are and where the deviation is, it especially can be helpful if it's someone you're not thinking is a surgical candidate. You can show them, look, there's a pathway for air, so maybe allergies are contributing, maybe there's mucosal disease. But I do think that there's a role for nasal endoscopy, and I use it specifically for that reason, even more so than standard imaging like CT scans or something like that.
And we're talking about nasal valve here. Is there a significant role for imaging in these patients?
I don't really use imaging very often. It's obviously it's something that they can use. This article does discuss that CT results can correlate with some findings, but it's not a consistent relationship. And so I routinely do not use a CT scan. And the times I would use a CT scan would be in complex revision surgery, or if there's questioning of a silicone implant or something like that. But very rarely do I personally rely on imaging. That does vary from provider to provider, and some people it does help in planning. But I think with nasal endoscopy, you can see, that's one of the good things about the surgeries we're doing here, is that you can kind of really see and understand what you're going to expect going in.
Thank you. So, the patients come in with a complaint, you've evaluated, you're doing lots of math in your head while you're calculating all these great formulas. But at the end of the day, it's all about how the patient does, right? So Robin, Dr. Lindsay, let's talk about outcomes. There are patient-reported outcome measures, or PROMs, and then there are objective outcome measures when you're talking about nasal valve repair and obstruction. So what measures are used, and what makes the most sense to use?
Yeah, so the first PROM for nasal obstruction that was developed is the nose score, and that's been in existence for about 20 years now. And that was really the first patient-reported outcome measure specifically looking at nasal obstruction, and that really has been the workhorse for many years. The SNOT-22 are really more looking towards sinus disease, and I think are utilized by our rhinology or general laryngology colleagues, but less utilized by individuals performing nasal valve surgery. Now, we also want to look at the appearance of the nose, as no one wants a larger, less attractive nose when they're undergoing even just functional nasal surgery. And so there's the face Q scores that were developed looking at nasal appearance. More recently, Sam Most and his group has developed the Schnoz score. And the Schnoz score is basically the nose score plus the face Q nasal score. So it both looks at the nasal obstruction as well as the patient perceived cosmetic appearance of the nose. Additionally, also what's utilized is a global quality of life scale, and that allows us to look at not just disease-specific quality of life or the impact of nasal obstruction, but also looking at global quality of life. Therefore, you can calculate health utility values and really demonstrate the significant impact that the nasal obstruction has on patients. And, I think as we're, talking about evaluation, patient-reported outcome measures are sort of one of those tools that we have in our toolbox. And it is helpful if you're seeing a patient and they've had their PROM in advance of the visit, that you can, going sort of in the door, so to speak, to see the patient, what their level of distress is with their symptoms of nasal obstruction. And then post-operatively, it helps you to ensure that patients are feeling better and that the surgery that you are providing is having the desired impact. I think as we're also looking at patients' indications for surgery, I think that breathe right strips are another. We didn't mention it with the evaluation, but I think it's another key piece, and how patients, sometimes you ask them if they use breathe right strips, they'll say, oh, that never ever helps. And that never ever helps sometimes is just because they're so desperate for surgery and they think that you're going to tell them to use breathe right strips forever. But actually, it's a really important piece of information if the breathe right strips work or not, because there's nothing magic with surgery. Also, patients typically will often put the breathe right strip too high on the nose and not on the flexible part. So it's always good just to ensure, one, to say, I'm not going to tell you to use them forever. It actually is an important piece of information for me to be able to guide you whether or not nasal valve surgery is correct for you or not, and then make sure they're positioning them appropriately. There was a consistent statement additionally, and I think it was in around 2010, that also discussed the use of nasal pharyngoscopy and CT scans. And it was determined that neither needed to be used for evaluation of nasal valve. However, it deferred, as Dr. Gadkari mentioned, it deferred to the provider. If you're concerned about sinus disease or a nasal mask, it's okay to do so, but it wasn't required. And so, moving along to the objective measures, there's several objective measures that have been used. I would say none of them are commonly used in clinical practice. One caveat to that is the PNIF that allows for maximum inspiratory pressure to look at nasal flows. However, the PNIF has not been shown to correlate to the patient-reported outcome measures and nose scores. However, the delta between pre and post-op PNIF has correlated to symptom improvement. Additionally, with the utilization of CT scans, as mentioned previously, this kind of 10 to 15 degrees. Unfortunately, CT scans can either over or undercall internal nasal valve narrowing, and so it's not utilized for evaluation of the internal nasal valve. It really is just anterior ionoscopy without dilation of the valve itself. And so when we look at computational fluid dynamic modeling, and there are some excellent images in the chapter by Dr. Xavier that demonstrate the computational fluid dynamic modeling in a patient with septal perforation, and then they were able to, on the computer, close off that perforation to demonstrate how once you close the septal perforation, you decrease resistance by decreasing turbulent airflow. So I think they're really used mostly for research purposes at this time, but they do inform our clinical decision making. Patient-reported outcome measures, though, I really feel have gone into becoming standard of care for evaluating patients with nasal obstruction.
Thank you. And I'll just point out to our listeners that in the article that Shaker and I were discussing before by Eng and Robichuk, they have actually reproduced the nose score, the nose instrument, the nasal obstruction symptom evaluation instrument. And it's very clear and it's easy for patients to answer. And the fact that it's a validated instrument that you can use pre and post-op is very helpful. I also like that you pointed out the pitfalls of people who just want surgery. And as Shaker said, just putting a Q-tip, just touching the nose, making them feel better, that's a red flag right there, right? Or somebody who says, oh, no, nothing works because I must have surgery. And I think, Robin, you saying, let me make sure you're putting that breathe right in the right place, because if that strip in the right location is helping you, then it's likely that surgery can help you, right? Is that?
Yeah, no, I agree. We really want to be very careful with our clinical decision making. And I think one of the wonderful things about this surgery is it's very much individualized to each patient. And I did want to also direct the listeners to a table that's in the chapter on patient-reported outcome measures by Dr. Fuller, and it really goes through all of the most commonly used patient-reported outcome measures. And additionally, it talks about something that's very important, which is the mentally clinically significant difference. And so when we're using these patient-reported outcome measures, it's good. You have to also understand where the severity breakdown is. For the nose score under 25, it's considered to have no symptoms of nasal obstruction, whereas over 85 is severe. And then understanding that clinically significant difference. So when you're looking at your results pre and post-op, you understand whether or not for a patient that's actually making a clinically significant difference, or if it's just a change in the number on the scale.
Thank you. That's really helpful. So, Shaker, the patient has met all the criteria. You think that the surgery is going to help them. So let's just do a couple of nuts and bolts. So what is the current standard of care for using antibiotics in rhinoplasty? And what about pain management? And are there any evidence-based documents like clinical practice guidelines that talk to this?
Yeah, so that's a great question, very practical. One of the chapters in this book is by Dr. Lee and Dr. Patel from Vanderbilt, and they discuss this issue in great detail. So I'll kind of split my answer up. So antibiotics and pain are two different things that we think about both, and there have been a lot of studies, but in terms of antibiotics, postoperative infections, this chapter actually looks at that and kind of estimates the amount of infections based off several other studies. And the general rate of infections for rhinoplasties are in the about 2% range. So it's not a super high. Some studies suggest that giving perioperative antibiotics may not actually matter, but routinely people are giving intraoperative antibiotics. And postoperative antibiotics are only given in special situations across the board. That's a generalization, but if someone's using, some people would give it for cadaver rib grafts. Some people would do it in complex revision cases or cleft cases when there's a lot of grafting, a lot of dissection. But in general, I would say that the majority of providers I've spoken to are routinely giving perioperative antibiotics, so maybe 2 grams of Ancef or something like that, but not routinely giving postoperative or preoperative. Certainly is very rare, so I don't really see that. So in terms of clinical practice guidelines, this article also discusses that. The World Health Organization recommends a single IV dose before incision, and the American Academy of Otolaryngology, HNSF, agree with perioperative antibiotics for a small decreased risk of infection, but they say if you're going to give postoperative antibiotics, either don't give them or less than 24 hours of antibiotics. So it's kind of a question that people study a lot, but the rate of infections are generally low, and there is a little bit of kind of thinking about who you think might get an infection. But that's what the article generally discusses as what's going on for recommendations.
Before you get to pain, can I ask
Yeah.
are you guys using packing in the nose? And does your antibiotic protocol change if there's packing, or are you using like a packing that's impregnated with something? Like what's literally, like I just landed on Planet Otology, right?
Mm-hmm.
Or from Planet Otology. So I need to know.
Yeah, so great question as well. Especially from Planet Otology. We are routinely putting in plastic splints now. So like Doyle splints, they're like plastic. They can't really be seeded by bacteria. So it's not like we're putting mirror cells in that often anymore. If I'm doing something like a complex case with like a bad nasal fracture and I'm trying to hold the nasal bones out and I thread a mirror cell in, then in that case, yeah, I would give antibiotics. But the vast majority of packing we do is 2 Doyle splints to kind of sit on either side of the septum. And because bacteria can't really sit on that, it's not like packing elsewhere or a bolster or something like that. So we're not really giving antibiotics for packing purposes.
Okay, thank you. That's my spaceship is grateful. And let's talk a little bit about pain management. So we need to be the stewards of this pain crisis, right? The pain med crisis in the world. So how do you steward that?
Yeah, for sure. So first, I think it's understanding what level of pain this is in relation to other procedures. And there's been some studies on that. This article by Dr. Lee and Dr. Patel, the first figure gives a nice representation of the nerves that are contributing to the sensory function of the nose. And it is kind of a lot of different nerves. The internal portion of the nose, the external portion of the nose, they all have sensation. So it is important to make sure that we're on top of pain. I think the opioid epidemic has kind of shifted a lot of how people are giving pain medications now. So I think the pendulum kind of swung to giving more narcotics. And then once people realized that short-term narcotics could lead to dependence, or that patients were kind of really needing a lot more of these narcotics and more of these studies came out, people switched away from narcotics. So this article discusses several studies that show NSAIDs are not inferior to opioids for pain control. And while some providers don't want to give them for an increased bleeding risk, there have been studies that show in rhinoplasty, it doesn't necessarily increase bleeding risk as well. So again, people have their preferences, people have had bad experiences, but the rate of postoperative epistaxis after rhinoplasty is pretty low, although it does happen. So whether or not you're willing to give NSAIDs is kind of a decision point that can help you get away from opioids. This article discusses different pain regimens and different articles of how pain regimens were given to patients. And the overall finding is that non-narcotics are first line, opioids are second line. But additional multi-institutional studies are needed. And I think that really mirrors my practice and the way I've seen it be practiced by several providers, in that we really shifted away from opioids, and only in special cases or for breakthrough cases where the patient is in a lot of pain would we give narcotics. So we really try to get away from that. We can do local blocks at the end of case, infraorbital nerve blocks. There is lidocaine infusion catheters for if you're doing rib harvests. But I do think in rib harvest cases, if you're doing something like that, then yeah, maybe you'd give narcotics. But in general, for just rhinoplasty patients, when you're doing nasal valve surgery, people are getting more away from that.
And I think just as surgeons, setting realistic expectations with our patients, everyone always asks us, right? Oh my God, how painful is this going to be afterwards? And I think that 2-minute pre-consultation in the office really sets the patient up for a good outcome and a good pain management outcome as well. So Robin, Shaker has mentioned a couple of times different sources of graft material. So he's talked about cadaver, he's talked about rib. So what graft sources are commonly used for nasal valve correction? And how do you decide what's the best one for the person in front of you?
Yeah, so Dr. Barbright discusses this in his article, and first talking about the intranasal sources. And so our favorite sources of cartilage graft are the septum. And this is really one of the reasons why it's so important to diagnose nasal valve compromise correctly so that a septoplasty isn't done first. Because once the septocartilage is gone, it's gone. And then you're looking at alternative graft sources. And so the primary graft source that we would like to use is the septal cartilage. Dr. Barbary also discusses use of perpendicular plate grafts. And in some patients, if you're just trying to brace the septum rigid and straight and you just need a thin piece of perpendicular plate and the patient actually has a thin piece of perpendicular plate, you can use the perpendicular plate as a graft. Then you start to get into graft sources outside of the nose. And I think for most folks currently, we are not using anything that is not human in origin. So, we try to stay away from MedPor, silicone grafts, just because of the rate of infection. Gore-Tex, the rate of infection is so high as the rate of extrusion, even many, many years later. And so some individuals will use, especially when they're utilizing a butterfly graft, will use conchal cartilage graft or ear cartilage graft because it's curved and floppy. And that works well for some indications. But if you really, in most of functional and cosmetic rhinoplasty, you want something that's rigid and straight. And so if you're looking for that, really you're looking towards the utilization of a rib graft. A rib graft can either be an autologous rib graft, which, as Dr. Gagkuri mentioned, you can use that graft, and that can cause potentially some increased pain. Though I think this is very technique dependent in the way the rib graft is harvested. And if you're careful with your surgical technique, you can have in some small incisions and also use a muscle sparing technique. So you're not cutting the muscle fibers you're dividing between. That can lead to significant decreased pain control, where the pain actually doesn't require more narcotics than the nasal surgery alone. Then with the, if you're not using a patient's own rib, and some patients are either that rib has already become osteophyte and you can't use it for grafting, or people are like, no way, no how am I going to have that scar or any additional pain associated with that. And that's really moved towards the cadaveric rib grafts. And rhinoplasty surgeons love to talk about different graft sources, and they're very strongly opinionated about the use of autologous graft versus cadaveric rib graft. And there's different processing techniques for cadaveric rib graft. There's also different availability worldwide of whether or not cadaveric rib is available in your country or not. So certainly what's available is going to impact your surgical techniques. But common cadaveric rib grafts are radiated rib or fresh frozen rib. And so both of those are sort of useful options for a cadaveric rib graft. People talk about using the central core of the cartilage as well to decrease warping. The reality is both autologous rib grafting and cadaveric rib grafts can all warp. They can all dissolve if you get a little fluid collection or seroma around between the graft and the mucosa. And you're never going to be able to do a randomized control study looking at one graft versus the other because it's human tissue. So really what we're able to look at it is in large prospective studies and retrospective studies, just looking at infection rate and revision surgery, which has really demonstrated that both autologous and cadaveric ribs are safe in our patient population. So really then it just comes down to surgeon preference. And a lot of it has to do with just where you trained, quite honestly.
Yes, as does so much of what we do, right? So, you mentioned spreader grafts, and I think that people are very comfortable with that concept of spreader grafts and butterfly grafts. I'll point out to our listeners that both of the articles on spreader grafts that you've included in this issue of Clinics have accompanying video content online that's really very illustrative, very nice to see. And this includes the article on the butterfly graft by Rist and Clark of UNC in Chapel Hill, North Carolina, and the article on closed treatment of the internal nasal valve by Boyce, Ovate, and Hetzler from LSU in New Orleans, Louisiana. So, having said all that, Robin, can you give us sort of the latest and greatest, the breaking news on spreader grafts? Has the rationale changed? Has the placement changed? As how, the access to it changed?
Yeah, and I think one of the things that Dr. Gadkari and I wanted to, in this issue of clinics for the specializing in the nasal valve, is to really start to standardize the nomenclature that's utilized in our field. And in speaking with many of our colleagues and other experts in the field, because it gets confusing and that we utilize different terminology for different areas, and even in some of our scholarly research, we're not consistently using terminology. And so, just to back up a little bit, and sort of we discussed where the internal nasal valve is and the angle between the the septum and the upper lateral cartilages. But you can imagine that if the septum is deviated in the dorsal component, that's going to impact the internal nasal valve. And so that narrowing can be caused by these long, floppy, thin upper lateral cartilages, but it can also be caused by dorsal septal deviations. And so it's important to sort of understand the differences there. Also, kind of looking in this terminology, we'll talk more about the external nasal valve in a bit, is just to look at it being sort of one unit of external nasal valve, of nasal valve compromise. And so looking at this as a static internal nasal valve, a static external nasal valve narrowing, and then lateral wall sufficiency or nasal valve collapse, and thinking that that is one unit. So backing up towards sort of the internal nasal valve, I think this change in thought process of the internal nasal valve, since it was described by Jack Sheen many years ago now, is that initially the thought was you're putting this piece of cartilage in and it's tensioning the upper lateral cartilages up, opening the internal nasal valve. And the thought process now is really what you're probably doing more is that you're creating scaffolding on either side of these dorsal septal deviations, and you're creating that's making that septum to be straight. And so that dorsal deviation causing the internal nasal valve narrowing is no longer narrowing the internal nasal valve, instead of this idea of tensioning of the upper lateral cartilages up and over, because it doesn't really make sense, right? If you're putting more cartilage in an area that's already narrow. And I think we want to move beyond this idea that every patient gets a spreader graft. I think every patient, we should, you do the septoplasty first so they haven't already had one. If the nasal valve is still narrow at that point, then you consider doing spreaders. But it may be because there's still a caudal septal deviation, you need to release the posterior septal angle from the nasal spine to allow the dorsal and caudal L strut to swing over. And you want to do these things in a very stepwise fashion to ensure that you really do need a spreader graft and you're not just narrowing an area that's already narrow. And so looking at sort of the placement of the spreader grafts, and, just as, the idea, for this issue came from us walking along the beach. As we were reaching out to our friends and colleagues in the rhinoplasty community, it was this article about spreader grafts came about really because I was talking to Dr. Hetzler, and we were talking about how the way we approach spreader grafts has really evolved. And what was interesting is that even though we don't speak frequently about spreader grafts, I guess, but we've both evolved our technique over the past 5 or 10 years in exactly the same way. We're at similar career stages, and you're taught, or at least in our generation of surgeons, were taught to open the nose, release the upper lats, upper lateral cartilages from the septum, place spreader grafts and suture those grafts down. And then you start asking yourself, well, do I really need to open the nose? Do I really need to release the upper lats? If I don't need to release the upper lats and I'm not doing anything that requires an open rhinoplasty, do I really need to open the nose? And so very stepwise, many of us in the field have kind of gone to a closed approach replacements of spreader grafts. And we've really done this sort of independently and then chatted later and said we're actually so many of us are doing exactly the same thing. So I was so excited when Dr. Hetzler wanted to write this article. I was like, that's fantastic, because that's exactly what so many people are doing. And so I think when you ask what this is the latest and greatest, I think this approach to the closed approach to placement of spreader grafts really is what a lot of individuals are moving towards. But again, it's done in a very sort of like thoughtful approach. You're still doing your septum first. You're releasing the posterior septal angle if needed, and then you're doing spreader grafts. You're not just putting spreader grafts in every patient out who has a nose.
Fantastic. Thank you. Lots of pearls coming from both of you. throughout this conversation. I'm Dr. Sujana Chandrasekhar. I'm the consulting editor for Otolaryngologic Clinics of North America. Today I'm speaking with Dr. Robin Lindsay of Harvard and Massachusetts Eye and Ear Infirmary and Dr. Shekhar Gadkari of University of Miami Miller School of Medicine. They are the guest editors of the April 2025 issue of Otolaryngologic Clinics of North America, which is on the nasal valve. You can access all of our issues, articles, and online content at the website, which is www.oto.theclinics.com. And you can access all of our podcasts. We have one per issue since 2017. And one each for two of our special article series at our website or wherever you get your podcasts. I'm really glad that Elsevier, who's our publisher, has made this investment into making this wonderful scientific knowledge freely available to people around the world. Okay, so let's get back to the conversation. So, Robin, we learned a lot so far about the internal nasal valve. And now I'd like to understand, before my rocket ship back to planet otology takes off, what is the distinction between lateral wall insufficiency and the external nasal valve?
Right. And so there's in the article with Dr. Jones, they talk about the evaluation and management of the external nasal valve. And they specify in there some very important features of the external nasal valve. And to look at the caudal deviation, which is demonstrated in figure 2, where you also see some what's called medial caudal flare. And those two statically narrow the external nasal valve or the nostril. There's also a great figure in there as well that describes the Q-tip maneuver or the modified caudal as well. They also speak about the importance of, in patients with caudal septal deviations, moving that caudal septum back into the midline with something that's called a swinging door procedure. And then just sort of the traditional different approaches to the external nasal valve with the alar batten graft that was originally described by Dr. Tardy back in the 90s, and really sort of the pluses and minuses of these different grafting techniques. Where alar batten grafts, sometimes if not placed correctly, patients will still have additional narrowing of the external nasal valve because of the weight of the graft, and then you can see them through the skin, making for some very unhappy patients that they still have nasal obstruction, as well as now this sort of nasal deformity, so to speak. Additionally, they discuss the placement of lateral crural strut grafts and alar rim grafts, with lateral crural strut grafts providing a very powerful workhorse graft to open up the external nasal valve, but can also cause some nasal crowding as well, because it's placed between the vestibular mucosa and the lateral crura. So you have to be careful that you're not narrowing the external nasal valve with placement of that graft. And also looking at alar rim grafts, which are placed right along the alar rim, caudal to the caudal edge of the lateral crura, and that you have sort of less nasal crowding with an alar rim graft. And then Dr. Most really initially was the one who described to zone 1 and zone 2 of lateral wall insufficiency, and really started utilizing the term lateral wall insufficiency and delineated it from just nasal valve compromise. And this is really where we're talking about nasal valve collapse. And he originally described it as zone 1 collapse, which is really the upper lateral cartilages, and zone 2, which is down towards the lateral crura, the lower lateral cartilage, and down to the external nasal valve. And so ways that you're correcting lateral wall insufficiency is that you're basically shoring up the side walls of the nose, and a very powerful way to do that is with a lateral crural strut graft. There's also the articulated alar rim graft, which is discussed in the article that was first described by Dr. Rick Davis at University of Miami. And so I think looking and really understanding the nuances of each of these grafting techniques will give you much more successful surgical outcomes.
Fantastic. So I'm just going to, this issue of clinics has, like I said, 17 articles. They are really fantastic. I'm just going to mention some that we're not going to be going into in detail. We've previously had an entire issue of clinics on ethnically sensitive rhinoplasty and on gender affirmation in otolaryngology, and I'm really glad that our guest editors have included an article on nasal valve compromise in non-Caucasian rhinoplasty by Feng Fuller and Derek Shan of Loma Linda University in California, and on gender affirming feminization rhinoplasty by Fakurnejad, Mohan Seth, and Knott of UCSF in California. I also want to highlight to our listeners the articles on saddle nose deformity by Pham Winkler and our guest editor of this issue, Dr. Gadkari of the University of Miami in Florida, and on the nasal valve in facial paralysis by Burks and Lyford Pike at Harvard Mass Eye and Ear Infirmary in Boston. All four are illustrative and with great figures and information. Please do go back to our website or to your article, your journal that you've ordered and is sitting in your hands, and read them. But let's go on to focus on even more complex situations than we've already discussed. So Shaker, Dr. Gadkari, revision cases of any type anywhere afford much more difficulty. The article by Parikh and Lighthall from Penn State Health in Hershey, Pennsylvania, covers this and emphasizes the use of graphs with excellent pictures. I know that you talked about revision surgery as something where you'd maybe individualize antibiotic care or maybe individualize packing, but what are the salient concerns when you have to do revision surgery at the nasal valve?
It's a great question. So revision nasal surgery is obviously going to be more difficult. You're going to be dealing with scarring. Someone's already been there. Specifically nasal surgery, often your graft opportunities are messed up because someone's taken the septum already. So this article is really a great comprehensive review. And it starts off by talking about performing a detailed physical exam. And I think in these revision cases, you have to be especially detailed because you're not just looking at a problem with nasal obstruction, you're looking at one that someone's already tried to fix and it didn't work. So that could have caused you more problems, and you need to figure out if you can offer this person a surgery that can really actually help them, or if the risk is too high and you're going to potentially make their problem much worse. So performing an equally, if not more detailed exam of where the issue is super important. So maybe in the first surgery, you want to figure out exactly what they did if you can. Oftentimes you don't have those reports, but sometimes you can figure out where grafts were placed. What did they do? Did they only address the septum? And then you identify a problem in the nasal valve. That's great. If they did a full surgery, maybe some of the grafts warped or deviated, and maybe you see the problem there. But you really want to figure out what problem happened and why it wasn't fixed in the first situation. So they could have persistent nasal obstruction that was there before and didn't get fixed because the issue wasn't fixed, or they could have a new problem and the nasal obstruction could be for a completely different reason. You want to look at how much septum is left and think about where you're going to get grafts from, because you almost certainly are going to need new cartilage to really support the nasal valves if you identify a problem in the nasal valve. And the point that I addressed earlier is, can you improve the patient enough to make a second surgery worth the risk? Because you're taking on this patient, you're taking on the patient's problems, and they're putting a lot of faith in you. And you don't want to be in a situation where they're going to go for a third revision because each one becomes incrementally harder. Now, the figures in this article are really great because they go over a lot of reasons why something could have gone wrong. So in figure 3, for example, they talk about an excessively long septum and how swinging door technique might help. And then in figure 4 of this article, they talk about when there's a huge deviation in the anterior septum and they do a septal replacement graft to really, because the septum is damaged in quality, which can happen after previous surgery, or if someone tries to just score the cartilage or take like a little bit out in kind of in an easier way to get kind of away from the surgery, then it can be really messed up when you go back for revision surgery. So they talk about anterior septal reconstruction. In the next couple of figures, they talk about the use of the septal extension graft and grafts to reposition the lower lateral crura. And in the text of the article, they talk about fixing the tip because you can have tip ptosis that can contribute to valve collapse. And then they talk about all the different types of grafting materials. So for example, if someone had a cosmetic rhinoplasty, their nasal valve could be very damaged, and you may have to replace the caudal septum, or I'm sorry, you may have to replace the lower lateral cartilages. Another thing that can happen is if someone's trying to narrow the nose and they do ALR base excisions, you're faced with a really tough situation because someone's taken out the skin. So it's really it's such a big category, but they do a really nice job of talking about all the different places that you can place grafts. And really, they're just basically talking about options that you can use to address individual problems that weren't addressed the first time or that came up after the first time. And I think the final point that I'll make here is that you can do a really good surgery, you can really address the problem, but scarring and infection and warping and all the problems that can ever come up with rhinoplasty are worse than a revision case. So you could do everything right, and you still could be on the hook with a something that didn't go perfectly right. So counseling those patients is super, super important in revision surgery, and that's some of the points that they make during their extensive discussion in this article, which has 13 or 14 figures. I forget exactly how many, but a really good review.
I'm just going to take a small left turn, because you talked about postoperative care and counseling. So how, I've seen people, I met my husband playing Ultimate Frisbee in Central Park. So I met him with a bunch of other lunatic people, and we would play hard back in the day, not now. He still plays hard. I sit, I rest. But back in the day, we'd smash into each other. We'd crash into each other. Suddenly this girl showed up with a big old, plastic, like Groucho Marx nose on top of her nose because she had just had surgery. And she wasn't supposed to smash into people with her nose. So what are your limitations, which is probably a good idea to begin with, but what are your limitations, Shaker, that you tell your patients, even with initial rhinoplasty, initial nasal valve repair, about trauma to their nose, or how, can they sleep on their face? Can they go back to playing basketball? What can they do?
It's individually tailored. So if it's someone who's a boxer or something, then I'm just don't get the surgery. Just wait. And then down the road,
we'll just tell them, learn how to do a crossword puzzle.
Yeah, exactly. Relax. If it's someone regular sports, obviously we need people to be able to live their lives. But if I'm doing something like osteotomies or shifting the bony work, definitely at least 6 weeks. I'm not having them do contact stuff. And for normal activities, I say 4 weeks in general. Even if I don't do osteotomies, I need things to kind of settle, and things are going to be really loose. Your grafts are setting in, and everything that you put in your grafts, you position them really well, but ultimately you need the body to put scar there to hold them in place. So at least 4 weeks for even heavy lifting, because I don't want anything to get shifted. 6 weeks for anything even remotely trauma related. And then after that, I would still have them wear face masks or things like that. But ultimately, I do tell them, we get so many calls into our office where it's someone after rhinoplasty and their kid hit their face, or something happened and there's a basketball. And I tell them, listen, whatever happens, we're not going to rush back into surgery now. If you do get trauma in your face, that's really unfortunate. We'll look at it in 6 to 9 months and decide what we have to do. And I tell that to people before when I'm counseling them, so they know that if that happens, it's something they're going to have to sit with for a little while. So there's some risk that they're taking on themselves.
Okay. All right. Good. So let's move on from these revision cases, which are really difficult, to something else that is really difficult, which is individuals with cleft lip and palate deformity. So the care of these individuals is very difficult from a nasal perspective, from an oral perspective, frankly, from an ear perspective with bad eustachian tube dysfunction. You guys included an article by Shea, Gengler, and Tollefson from the University of Cincinnati and University of California, Davis. And this has a lot of information. So, Shaker, can you tell me what are the special considerations in patients who have cleft lip and palate?
Yeah, so there are so many. And what my number one special consideration is these cases are really hard. So, you have to know that going in, you have to counsel the patient and know that you may not be trying you're obviously going to be trying for a perfect result, but you may not be headed for the same perfect result that you are when you're doing a cosmetic rhinoplasty, for example, because there's just so many abnormalities that you're going to be dealing with. So that's kind of the overall thing, is that it's going to be hard. You counsel the patient on that. You're going to have a lack of lining of the nose, for example. You're going to have forces that are trying to deviate your grafts, and you're going to have some asymmetries that you're going to be really fighting against during these cases. So you need strong grafting material. You need to really assess how much laxity the skin has. And all of these things are I'm talking about cleft rhinoplasties in general. This article is really great, and it goes over cleft rhinoplasty from a primary rhinoplasty perspective, which is when you're fixing the cleft lip. So when they're babies, what can you do to kind of go over it? And this article has a great series of tables and not just figures, but they talk about the clinical characteristics in their first box of unilateral cleft nasal deformity. So you have an asymmetric tip. There's flattening of the nostril on the cleft side. The medial crura is shorter, and the lateral crura is lengthened, and the alar base is displaced laterally, inferiorly, and posteriorly. And these are things that you note on unilateral cleft deformity. It also goes over bilateral cleft nasal deformities, where you have an underprojected tip. The medial crura is shorter and the lateral crura is longer, and there's a short columella with wide alar bases and flattening of both nostrils. And then when you're looking to analyze these patients, you want to, just like you're doing a regular nasal analysis, you want to separate each part of the nose. So for the nasal tip and the columella, you want to look at the projection, the rotation, and how short the columella is and how much skin give you might have to project the nose, because you're going to need to project the nose when they're under projected. The septum is usually horribly deviated, posteriorly and anteriorly. You're going to want to look at the nasal valves, and especially the lower lateral crura, where it's going to be flattened and shortened and posteriorly displaced. And you're going to have to kind of refix that. So in a primary cleft rhinoplasty, there's a nice figure 4 that they have here, where they are going over how you can utilize lip incisions when you're doing your cleft lip repair to help with the rhinoplasty down the road. And the main point of this is to try to normalize tip symmetry by decreasing excess alar hooding and address the alar base using these lip incisions. And that's honestly not going to be a perfect repair for the most part when they're, in their first year of life. But there are different things you can do to set yourself up for success. And they go over that in this article of how to kind of make the lower lateral crura and cartilages to be more symmetric through those lip incisions. So that's really good. And this article kind of discusses a lot of the techniques we use in secondary cleft rhinoplasty as well, when you're going to be looking at repairing a nose that's been basically deformed from birth. And they talk about a lot of techniques that we use every day. And in my fellowship, which I did with Dr. Hilger and Dr. Lightford Pike, who wrote an article here as well, we used to call it alphabet soup. And they go over a lot of the techniques. And the reason we call it alphabet soup is, for example, for your columellar lengthening, your columella is short. So you might do a V to Y advancement flap to get just a few millimeters, so you get a little bit more projection. And they go over that in figure 8 in this article. In figure 6, they go over a reverse U incision with a Z-plasty modification. And that's because your mucosa is always going to be tethered on the inside of your nose. So if you perform a Z-plasty of the mucosa, you can get extra length by rotating those mucosal flaps. So that's another technique we use. And that's shown in figure 6 of this article. And then they also talk about in figure 11, lateral crural steal, which you often need to do to try to normalize the length of the crura. And because you're stealing from a deficient crura of the lower lateral cartilage on that side, you often have to do batten grafts or lateral crural strut grafts or something to lengthen the cartilage. And really, the other thing that's going to limit you is going to be the skin and the columella, and you just may not have the projection that you normally do to try to normalize everything. With that said, you can make immense differences to these patients because there's a lot of room for improvement. These cases are just really hard, and even though they aren't revision cases usually, even the primary ones can be quite difficult. So this article does a really nice job of going over a lot of the techniques you can use which can gain you just millimeters of length here and there, and that can lead to a vastly superior outcome. And so it's really a long-term process where you can be set up for success in the primary rhinoplasty phase, and then when they're 18 or adults, you can figure out what you can offer them to really fix their cleft rhinoplasty.
Thank you. Yeah, it's really a very step-by-step and systematic approach that I think takes a very challenging and almost mystifying situation and makes it approachable in a systematic way. So the last article I want to go over with our guest editors is the article by Suarez, Jussac, and Sydney Butts from SUNY Downstate Medical Center in Brooklyn. We talk about cutaneous squamous cell and basal cell carcinomas. We actually had a whole issue on cutaneous carcinoma of the head and neck previously in the clinics. We try to tell everyone to use sunblock and not cause sun damage, but unfortunately, we continue to see cancers, and with the nose being sort of the most hit by sun part of our face, we're going to see some lesions here. So what are the considerations, Shaker, that need to be taken into account when patients present, maybe directly from their dermatologist's office who've had Mohs surgery and now they have a significant nasal valve defect?
Yeah, this is kind of a great switch of pace here, but these patients often come in and the number one thing people always think about is the cosmetic outcome. So I like this article because it discusses the functional outcomes that people may not necessarily think of, patients especially when they first are getting a skin cancer removed. So I think the number one thing is what aesthetic subunits is this Mohs defect going to be causing? And that's what patients are focused on. But as a provider and people that understand the anatomy of the nasal valve, we also have to think about what those areas mean for the way that the nose is functioning. So this article, table 1, I thought was really interesting in this article because it discusses that airway patency is the most important functional consideration. So that doesn't necessarily mean aesthetic, because I would say a lot of patients would probably be more focused on the aesthetics, but that's just temporary. Down the road, they're going to be worried about not being able to breathe. So they actually looked at a bunch of articles. They spanned from 1998 to 2017 and stratified by the nasal subunit removed, and showed that around 1 to 3% of nasal obstruction among ALR subunits would have significant obstruction following reconstruction. And what they're really trying to advocate for here is showing that if you add cartilage grafting to ALR subunit reconstructions, you can improve airway patency. So they give several examples of areas that you can let granulate themselves. So for example, in figure 3, they show just secondary healing of an area that's a concave defect. So light's kind of not really hitting that area, and they didn't have to do much for that. And there was no impact on the ALR rim there because it was at the superior aspect of the ALR crease, and it was a small defect. But for an entire ALR subunit defect, they show an example in figure 4 where they do put a cartilage graft in and they didn't have nasal obstruction. So in the text of this article, they talk about a study by Ezat looking at ALR and sidewall defects, and they found no nasal valve compromise in patients where they placed an auricular cartilage graft along the length of a defect in a non-anatomic, meaning spanning exactly where the defect was. But they cited around a 10 to 15% rate of valve collapse in those patients that weren't reconstructed with a cartilage graft. So I found that really interesting. But a lot of times we base it based on how big the defect is. And they recommend area defects that are sidewall defects greater than 1.5 centimeters. You should be really considering putting cartilage in. And if you have 50% sidewall or ALR defects that are even greater than about 1 centimeter, you can really consider doing it. I think for the way I look at these patients, intuitively, we kind of look at how close it is to the ALR rim, how close it is to the nostril margin, whether it's going through the cartilage and disrupting the cartilage. And then I decide it needs a cartilage graft. But we're so comfortable with the nasal septum, with the post-auricular cartilage graft, that it's not hard for us to get cartilage grafts. And I think that's where we can add a lot of value. I think that various other people do Mohs reconstructions as well. It's not just facial plastic surgeons or ENT surgeons. So sometimes patients will come to you secondarily after they've had a reconstruction, and you'll see the results of not having a cartilage graft from surgeons that maybe aren't as familiar with placing them, so it's a bigger deal, or if they're taking smaller amounts of tissue to reconstruct an area that needs more tissue. And I think those are the points that they've kind of made in this article of where we can benefit patients the most in nasal valve Mohs reconstructions. And really they're advocating for considering cartilage grafting as much as possible in areas where you even think the nostril margin is too close so it doesn't retract up, or where the cartilage has been violated and you're really looking at a nasal valve defect.
Thank you. That was a great discussion. Thanks so much. I want to thank you both, Robin and Shaker, for putting together such a terrific issue of otolaryngologic clinics of North America, and then for taking the time to record this podcast with me and really explain things in a fantastic way. Robin, I'd like your final thoughts about this. This journey started almost 2 years ago with us. So would you like to say a little bit more before we sign off?
No, definitely. Thank you for the opportunity. First, I want to thank Dr. Gadkari for agreeing to help out with this issue and helping to brainstorm about topics that would be of interest to our community, and then identifying really the right kind of diverse set of authors for the chapters. And I really want to also just thank all of the authors. There are so many amazing contributors that just put together really beautiful figures and beautiful articles, for this issue of clinics. And so I just want to thank them and all of their hard work as well.
Fantastic. I'm Sujana Chandrasekhar. I'm the consulting editor for Otolaryngologic Clinics of North America. And today I've had the immense pleasure of speaking with Dr. Robin Lindsay, who's associate professor at Harvard University and Massachusetts Eye and Ear Infirmary in Boston, Massachusetts, and Dr. Shaker Gadkari, assistant professor at the University of Miami Miller School of Medicine in Miami, Florida. They are the guest editors of the April 2025 issue of Otolaryngologic Clinics of North America, which is on the nasal valve. As I've said, you can access all of our issues, articles, and online content at www.oto.theclinics.com, and you can access all of our podcasts, and we have one recorded per issue since 2017, as well as one for each of our 2 special article series. One of which was on COVID-19, and the other was on intentionally shaping the future of otolaryngology at our website or wherever you get your podcasts. And as always, constructive criticism and feedback are greatly appreciated. So thank you so much, Robin, and thank you so much, Shaker, and thank you so much to our listeners.
Thank you for joining us for this edition of the Otolaryngologic Clinics podcast series. For an exclusive discount on the issue we discussed today focusing on the nasal valve, visit us.elsevierhealth.com/expert. Otolaryngologic Clinics is available for individual print subscription with accompanying online access or individual online-only access, and is also available on Elsevier's electronic platforms Clinical Key and Science Direct. For more information on this series and our 60 other titles spanning all medical disciplines, visit info.theclinics.com. Be sure to follow us on LinkedIn and subscribe to the Otolaryngologic Clinics podcast wherever you get your podcasts, and thanks for listening.